So next is chapter 10 we're going to start. It's endocrine surgery, and the first topic is V1, adrenal incidentaloma. Again, a high yield topic. 63-year-old man having a CT colonography has a 30 millimeter lesion detected on his right adrenal gland. A GP colleague of yours has asked for advice on this patient. So it is important to determine radiological and functional characteristics of this lesion. 1% of the abdominal CT scans have adrenal lesions identified, and initial assessment should stay on the history of all these adrenal cortex and adrenal medullary hormones like anxiety, palpitation, headaches, feeling of impending doom, dysmenorrhea, hypertension, diabetes, previous or current malignancy, and family history of endocrine disease to rule out MEN syndromes. Then perform a general physical examination and see any signs and symptoms of pituitary adrenal axis imbalance, obesity of face or trunk, buffalo hump or moon face, facial plethora, hirsutism, hypertension, proximal muscle weakness. These symptoms occur in 50% and more of the patients who are Cushingoid. So what's your differential diagnosis? So these adrenal lesions can be either functional lesions or non-functional lesions. If we talk about the functional lesions, obviously whatever the cells they are, they can produce the lesion. So if it's in the adrenal cortex, it could be adenoma, it could be nodular hyperplasia, or it could be carcinoma. If it's adrenal medulla, then it's pheochromocytoma, ganglioneuroma, and blastoma. And then is the non-functional. Non-functional are adrenal masses like lipoma, cyst, hematoma, teratoma, amyloidosis, and neurofibroma. And then are the METs, brain, lungs, renal, and lymphoma. Then leukemia, and then pseudorenal masses like lymph nodes. How would you investigate? So baseline and specific investigation. So baseline you need an FBC full blood count and urinary. To rule out pheochromocytoma, we need plasma metanephrine and 24-hour urinary metanephrines. And for Cushing's, we need overnight dexamethasone suppression test by 1 milligram dexamethasone at 11 p.m. and 9 a.m. check the level for cortisol. And if patient is hypertensive, then we should check for renin aldosterone. And if hyperandrogenism, then we should rule out, but we should check the plasma sex steroids. How do you diagnose adrenal lesions and a CT scan? So they are diagnosed by Hounsfield units. So Hounsfield units is a specific density of X-rays on the